Hello, my name's Florence. Welcome to the theobspod. I'm an NHS obstetrician, hoping to share some thoughts and experiences about my working life. Perhaps you enjoy Call the Midwife, maybe birth fascinates you, or you're simply curious about what exactly an obstetrician is. You might be pregnant and preparing for birth. Perhaps you work in maternity and want to know what makes your obstetric colleagues tick, or you want some fresh ideas and inspiration. Whichever of these is the case, and for that matter, anyone else that's interested, the theobspod is for you. Episode 146. Thyroid and Pregnancy. It seems extraordinary that it's taken me until episode 146 to think about the thyroid in pregnancy. It's something that I see women to discuss week in, week out in my antenatal clinic. But one of the reasons I've turned to this topic today is that the RCOG, the Royal College of Obstetricians and Gynecologists, are formulating their Green Top guideline on thyroid disorders in pregnancy, and it's currently out for peer review, a draft of the guideline. I thought about waiting until the draft is completed and the final guideline is put out. But this is the first guideline that they have produced on thyroid disorders in pregnancy, and that in itself is quite surprising. Why have we not had one before? So I thought to avoid further delay, I would talk about it a bit today. And all the usual caveats apply. I am not a specialist. I am not an endocrinologist. These are just my views and a bit of information from that current draft Green Top guideline. The first thing to say, I feel, is that some of my midwifery colleagues get a little bit confused between hypothyroid, that is when the thyroid gland is underactive, and hyperthyroid, when the thyroid gland is overactive. And these are two quite different situations and require quite different monitoring and quite different implications for both the woman and her baby. What is the thyroid? The thyroid is a gland positioned in the neck, and it produces two hormones. These hormones are T4, thyroxine, what people often think of as thyroid hormone, and T3, or triiodothyronine. Although T3 and T4 both come from the thyroid gland, a lot of T3 actually is produced peripherally, so outside of the thyroid gland, by conversion from T4. And to make these hormones, it's important for the thyroid gland to have iodine. Iodine is absorbed from the gut during digestion and transported to the thyroid, where it's trapped by the follicular cells of the thyroid and then used to make T3 and T4. What are these hormones used for? Well, they're used for energy production. So they're used in the way our cells release energy. So effectively, they're to do with your metabolic rate, how your body converts energy. But they're also used to synthesize, that is, produce and make proteins, and important for growth in children. So they're important hormones. The production of these hormones are stimulated by a hormone called thyroid stimulating hormone, or TSH. This is made in the pituitary gland in the brain, travels to the thyroid gland, and then stimulates the release of the T4 and T3. So that's your basic kind of thyroid understanding. And this system works on what's called a negative feedback loop. If thyroxine levels are low, then TSH, thyroid stimulating hormone levels, will go up to drive more production of the thyroxine. And if the levels are high, the TSH, thyroid stimulating hormone levels, will go down because they don't need to drive as much production. And this negative feedback loop is also controlled by something called TRH, thyroid releasing hormone. So if we start first with an underactive thyroid, then what can happen in pregnancy is the thyroid hormone levels are low and the TSH, thyroid stimulating hormone levels, go up. So when you book a woman in pregnancy who's on thyroxine treatment tablets, it's important to take her T4 but also her TSH. And the TSH is what we actually use to adjust her medication. And this is backed up by the new Green Top guideline that we should be taking free T4 and TSH levels in women in pregnancy. Most women with an underactive thyroid will need some increase in their thyroxine levels in pregnancy. Estrogen causes an increase in thyroid binding globulin in the plasma in the first half of pregnancy. And this is one of the reasons why we need to increase the dose. It then plateaus by the mid-trimester. And what we're aiming to achieve is a TSH of less than 2.5. And this reference range is slightly different from outside of pregnancy. So we want to slightly over-replace. And if you look at the Green Top guideline, it's suggesting that most women will need to increase their thyroxine medication by 20 to 30% during the course of pregnancy. And usually what we see is that there's a need to increase things early in pregnancy, in the first trimester. And indeed, the Green Top guideline backs that up. It in fact says that women should be increasing their dose of thyroxine by 25% pretty much as soon as they get a positive pregnancy test. And then we should be checking their thyroid levels every 4 to 6 weeks until 20 weeks, and then once again at 28 weeks. And then usually what I tell women is we'll need to check it again postnatally, because it may be that the dose will need to reduce. And that can be managed by the GP at the routine postnatal check. So often in the clinic, I will see women who've been booked, their TSH is high, I need to increase their dose, and usually we need to increase the dose by increments of 50 micrograms. I was always taught by an endocrinologist that I used to work with that 25 micrograms made very little difference to a woman's thyroid levels, and that usually will go up by 50 micrograms and then check blood tests in 4 to 6 weeks, because it takes that amount of time to see if there's a change. So I'll see women at maybe 12 or 16 weeks, make sure that we've increased the dose, that the changes have been effective, and then once things have stabilised, we'll do it once more with her routine 28-week blood tests, and that's pretty much job done. And these changes in dose are important not only for the mother's well-being. So if she's got an underactive thyroid, she may feel exhausted, she may suffer from constipation, excessive weight gain, feel very lethargic, but it's also important for her baby, as the T4 crosses the placenta and has an effect on the baby's growth and development too. There's some discussion in the Green Top draft guidance about iodine levels, which is interesting because it isn't something I've given much thought to. But of course, they're thinking about a more global audience, and this is of importance because iodine deficiency worldwide is the leading cause of preventable neurodevelopmental defects. It's saying that actually across the world, iodine deficiency is a major contributor, and it suggests that women need an iodine intake of between 200 and 250 micrograms a day. And it looks at some papers and data about iodine deficiency in the UK and says it's quite controversial whether women in the UK should be taking iodine supplements in pregnancy or not. There's some evidence that there isn't deficiency, and there's some evidence that there may be insufficient iodine in second and third trimester of pregnancy. So it's quite unhelpful. It does say that if iodine supplementation is required in iodine deficient populations, then it's important for this to be at an early gestation, and that makes sense if we're trying to affect the neurodevelopment of the baby. So it talks quite a lot about insufficient data and also the downsides of iodine supplementation and even small risk of acute iodine poisoning. It suggests that the oral iodine supplements in doses in the common prenatal supplements taken in the UK during pregnancy or breastfeeding are unlikely to be harmful and may be of some benefit. And a bit like I discussed in my episode on nutrition, that's episode 93, diet, I feel slightly embarrassed that I haven't really thought much about iodine levels or iodine supplementation and iodine requirements in pregnancy, despite having seen many women over the years with thyroid issues in pregnancy. Maybe that's partly my UK practice lens, but maybe that's just ignorance, and actually as obstetricians we need to pay more attention to diet. Before I move away from hypothyroidism, there are a couple of other things to discuss. Often I will now see women who have been started on a tiny dose of thyroxine, probably 25 micrograms, by a fertility clinic or IVF clinic. And I find this quite difficult to manage. They're not women that have had a formal diagnosis of being hypothyroid or underactive thyroid, but as part of their fertility investigations and treatment, it's been suggested that their thyroid hormone levels are borderline low, and therefore as part of their fertility treatment and help in getting pregnant, they've been started on this tiny dose. And I've noticed this increasing in recent years, a steady stream of women coming to me on 25 micrograms of thyroxine. And normally I will continue this medication and check their thyroid function just in the same way as I would for any other woman who is deemed to be hypothyroid and is on thyroxine treatment. But often their blood tests look normal, and I don't want to stop the thyroxine, but at the same time I'm wondering what is the value of that teeny tiny dose. Like I said, not an expert, I'm just giving you my thoughts and experience. And if you look at the green top guidance that's out for review, there is quite a large section on subclinical hypothyroidism and sort of whys and wherefores and what we should be doing and what the evidence may say. Now I'm going to turn to hyperthyroid or overactive thyroid. And in the first trimester, first 3 months, this can be quite complicated because we will routinely check thyroid function in women with excessive vomiting or hyperemesis, and that is because the pregnancy hormone beta-HCG interacts with the thyroid and actually stimulates the thyroid gland, and this can cause transient hyperthyroidism. So this doesn't require treatment with anti-thyroid medication. It requires treatment of the hyperemesis, and it will usually settle down. And this needs to be differentiated from thyrotoxicosis, when the thyroid is overactive, producing too much thyroxine, which also can complicate first and second trimesters. And this occurs in about 2 per 1,000 pregnant women, and the majority of these women will have known hyperactive thyroids before pregnancy and be on treatment. There are 2 usual drugs that women take for an overactive thyroid. One is carbimazole and the other one is propylthiouracil or PTU. And usually we prefer a woman to be taking PTU during pregnancy, and if a woman's been cared for by an endocrinologist and is planning a pregnancy, they will usually switch her over medication-wise pre-pregnancy. But if a woman falls pregnant and is on carbimazole, we may be switching her across to PTU. And this is something that I would get an endocrinology colleague to see a woman for. This isn't something that I would expect to manage myself. Both these drugs do cross the placenta, and therefore we want to maintain the woman on the lowest possible dose of medication. 95% of cases of thyrotoxicosis is caused by something called Graves' disease, which is an autoimmune condition and has TSH receptor stimulating antibodies. And a woman with symptoms may be vomiting and unwell. She may have a high pulse rate, experience palpitations, but again, it would be unusual to diagnose this for the first time in pregnancy. These women need seeing by an endocrinologist and obstetrician much more frequently, and their thyroid function needs to be tested monthly so that we can adjust the prescription of their anti-thyroid medication regularly. So this is why it's really important for midwives to differentiate between hypothyroid treatment with thyroxine and hyperthyroid treatment with PTU or carbimazole, because they need very different levels of expertise, monitoring and blood tests. The other important factor about Graves' disease is that if there are TSH receptor antibodies, these need checking in the first trimester at 20 weeks and 28 weeks, and these babies need blood tests of their own thyroid function in the neonatal period. Hyperthyroidism is thought to have much more impact on pregnancy complications. There are some suggestions that there could be some relationship between preterm birth, miscarriage, but it's difficult to correlate the evidence. If you look at the green top guidance, it suggests that women with high TSH receptor antibodies should be perhaps encouraged to delay pregnancy. And some women will have treatment of their thyroid with radioactive iodine or treated with a thyroidectomy surgery to treat their disease definitively and also make pregnancy complications and treatment less complex. Radioactive iodine should never be used in pregnancy itself, but the use of this or women that have had surgery for an overactive thyroid can confuse things still further for health professionals, because we may see women that have had Graves' disease, had definitive treatments such as surgery or radioactive iodine, and then they are started on a maintenance dose of thyroxine because their own thyroid gland is unable to produce it. So in effect, they've gone from being hyperthyroid to being hypothyroid. Okay, so not a definitive guide, definitely not my area of super expertise, but my brief take on the various sorts of things I see when women come to me in clinic. For my zesty bit, I think the key thing I would like to say is for health professionals, know whether you're dealing with a woman with an underactive thyroid, which is quite simple and can be managed with a series of blood tests, and then with your local obstetrician and GP reviewing the results, or whether the woman has hyperthyroidism and actually needs more specialist endocrinological support and guidance, which you should be able to access via your maternal medicine clinic if the woman isn't already seeing an endocrinologist out of pregnancy, which she often will be. For a woman with a thyroid condition in pregnancy, know that whilst things have been stable potentially out of pregnancy, pregnancy may require some changes in your medication and some more frequent blood tests, and that between us and the endocrinologists and your GP, we are well able to look after you during pregnancy and make sure that the impact of this on your pregnancy, birth, you and your baby can be very minimal. I very much hope you found this episode of the theobspod interesting. If you have, it'd be fantastic if you could subscribe, rate and review on whatever platform you find your podcasts, as well as recommending the theobspod to anyone you think might find it interesting. There's also tons of episodes to explore in my back catalogue, from clinical topics, my career and journey as an obstetrician, and life in the NHS more generally. I'd like to assure women I care for that I take confidentiality very seriously and take great care not to use any patient identifiable information unless I have expressly asked the permission of the person involved on that rare occasion when it's been absolutely necessary. If you found this episode interesting and want to explore the subject a little more deeply, don't forget to take a look at the programme notes where I've attached some links. If you want to get in touch to suggest topics for future episodes, you can find me at theobspod on Twitter and Instagram, and you can email me theobspod@gmail.com. Thank you for listening.